Thanks everybody for coming. My name is Dr. Reitz. I'm one of the general surgeons here. There's 4 of us. We also have a gastroenterologist, Dr. Syed, from a colorectal standpoint. This is my second doc talk that I've had the opportunity to do for Knox. My first one was for robotic surgery. I'm heavily invested in robotic surgery and I've been doing that for about 13 to 15 years. So today we're going to talk about colorectal cancer and awareness. So every cancer has their month. Right, so March is Blue Month for colorectal cancer awareness. I know that the hospital was putting out some screening kits and whatnot, so I don't know if you guys had the ability to participate in those. Sometimes it's nice to be able to participate in those free things that the hospital gives out. The problem is if you had a positive study, you should have come to see one of us, or you should be coming to see us. But colorectal cancer screening, we'll get into what it is, why it is, how it is. And this is obviously a Q&A session. I like to talk, I like to move. At the end, you guys can ask questions and whatnot, but this is, we're going to talk about what is it, where is it, how do we diagnose it, how do we take care of it. There are a few endoscopy pictures, but there's no icky surgery pictures, okay? So I didn't want to gross anybody out there, okay? All right, so let's talk about our inside. So what's a colon? So we've got lots of bits and pieces on the inside of us, but our colon is basically a big question mark, okay? If you can see the backlit area, we have our liver, we have our stomach, we have our small intestine, and the colon is the large intestine, and it's for obvious reasons. The small intestine is small, large intestine is large. Okay, but the large intestine goes up, over, down, around, and out. It's just a big racetrack. Sometimes people have different lengths of different sections, just like people have big nose, big ears, big hands, big feet. Sometimes people can have big colons. Unfortunately, we see that operatively and the endoscopy lab as well, trying to get around that racetrack. But from an anatomic standpoint, it's separated into the cecum, which is the first part, the ascending colon, the transverse colon, the descending colon. All of those make sense, right? Sigmoid colon, just because it makes like a big S here, and then the rectum as well. Now the appendix is here, it's kind of backlit. Appendix does hang off of that, but the appendiceal cancers are not included in these statistics, okay? All right, so when we screen for colorectal cancer, and we'll get into colonoscopy here specifically in a second, we're basically talking about what do we need to worry about. Polyps and masses, and we'll show a couple of pictures about what the difference is. Now polyps would be like skin tags. Okay, or freckles or moles, or we have flat lesions on our skin, or we can have little skin tags that look like mushrooms growing out of our skin. Those are called pedunculated polyps. Polyps, by definition, are non-cancerous, but they have malignant potential, and we'll get into that here in a second. Most common are called adenomas. There's some subclassifications there that you guys don't need to worry about. Other types of polyps are hyperplastic polyps, inflammatory polyps. Again, skin tags, warts, moles, zits, just little things on the skin, okay? It also takes a lot of years to transition into a full-blown cancer. So if you leave a polyp alone, it will get bigger and bigger and bigger. So when you come to see me in office, as I'm talking right now, I say, I'm just a fancy gardener. I'm just looking for dirty weeds in your garden, okay? And if I see a weed, I pluck it. Okay, so those are the polyps. Now, there's different types of weeds that your garden can grow, and there's some weeds that I worry about, and there's some weeds that I don't have to worry about as much, okay? But again, almost all cancers of the colon start as some sort of growth or abnormality as a polyp. From a mass standpoint, obviously big, bulky things that are way beyond a little bitty polyp, you can have different things in the colon. You can have benign lesions. Remember, benign means not cancer. Benign just means it is a growth, but it is not malignant. So you can have growths on your skin, a la a skin tag. That is a benign skin lesion. It is a growth, but it's not cancer. So we just have to watch our nomenclature there. And of course, we can have full-blown cancer mass as well. And we'll see some pictures here in a second. First, icky picture. Okay. This is a colonoscopy view of the inside of your colon, specifically your transverse colon going across. This is a sweet looking colon. Okay, this is nice. It's got nice big rings. You can throw a bowling ball down that and not any pins or anything. So there's no growth, no masses, no lesions. This is what the inside of our colon looks like. The little white spot is actually the reflection of the light off of the glistening surface of the inside of our colon. And also, when we do these, I always tell my patients we're just doing a fancy building inspection. However, if we're doing a building inspection, I can't have any furniture in the hallway, if you know what I mean. This is all the way over on the right-hand side. So this big thing right here is one of what we call our tinea coli. That little hole right there is actually our appendiceal orifice from the inside. Sometimes physicians call this the Mercedes sign, okay, because we're looking for that. That little guy right there is the end of the road. Here is a benign lesion on the inside of the colon. So this is called a lipoma. A lipoma is just a little fatty tumor. Again, tumor as in abnormality, not tumor as in cancer. And this is really technical. We call this the pillow test because it's soft and spongy, but it's just a big piece of fat that grows on the inside of the inner walls of the colon. That is not cancer, even though it looks pretty big and bad, but that doesn't need anything. And this is one of our instruments reaching out and touching it to make sure it bounces like a pillow. So that's called the pillow test. But this is a pretty good looking colon. Now, let's talk about some of the things that we don't like seeing when we do our colonoscopies, okay? So this little thing that looks like a brain on a stalk or a mushroom, that's polyp. That's a certain type of polyp. We call that a pedunculated polyp because it's kind of on a pedicle, if you will, or look like a mushroom. This one's a little bit shorter. He doesn't have this big tree trunk here. It's just kind of a brain sitting on there like a sea anemone. But these would get biopsied. This one would definitely get removed. This one, what we can do, he's pretty big. Sometimes what we'll do is we'll throw a lasso over it and cut him off. Okay, kind of like picking a mushroom off, and we need to make sure that we get as low as possible. And I'll show that reason for a while. Now this person's a little bit different. He or she's got lesions all over the place, okay? And so this particular person actually has a genetic disorder called FAP, or familial adenomatous polyposis, where these individuals, which is inherited genetically from mom or dad, where they can have hundreds, if not thousands of polyps in there. And that is a different ballgame. We're not going to talk about that. A couple more polyps here and there. Simple polyps, there's another little brain here, except this guy, this is like Sesame Street. Which one of these isn't like the other? Okay, so that one's big and bad and nasty. So this one is actually a cancer, and we do see it. This is an actual picture of a colonoscopy, and so this is what we're looking for when we're doing colonoscopies. Even though we have these little ones here and there, they all do get removed. Unfortunately, I can't take that out. Okay, with our little teeny skinny scope, though this actually needs surgery. Now we will take samples of it, take biopsies of it, but bigger lesions cannot be removed in their entirety a majority of the time. But we try our best. Okay, so this is the important slide from a physician perspective of what do we worry about with the polyps. Again, as we let a polyp grow, it gets bigger and bigger and bigger, and the roots can get deeper and deeper and deeper. So we like to get our polyps removed somewhere down in here, okay? So even though they are polyps, they are benign polyps. So these are your skin tags and your moles, okay? However, when we get abnormal cellular proliferation inside of that polyp and we let it grow and grow and grow, the cells start to get uglier and uglier, and this is a cancer within that polyp. Now, just like a tree root grows down, and we're not going to get too much into the anatomy, but you can obviously see our different layers here, it can start to invade different types or different linings in the wall of our colon. And this one's really, really bad because he broke all the way through the house wall, okay? So usually, the bigger the cancer is, the more worrisome it is, but we can still have little cancers with little polyps with cancerous spots in them. So that's why it's very, very important for us as endoscopists to get as much of the polyp off as possible, as low as we can, so our pathology colleagues can look at it accurately underneath the microscope, so they can look at the individual cells and tell us what is cancer or what is not cancer. All right, so testing, what are our options? We're going to get into some things about how we can test, and we're going to talk about the difference between a screening test and a diagnostic test. So screening tests are for the masses. We want to make sure you don't have something, okay? The search for an unrecognized disease by means of a rapidly applied test or exam or a procedure in apparently healthy individuals, okay? Screening is for individuals without signs or symptoms. So this is my quote. You're not here because you have a problem, you're here to make sure you don't have a problem. Diagnostic, or if any lady in here has had to unfortunately get a diagnostic mammogram, you get your screening film, they find something wrong and they say, there's a spot there, we need to look at it. So you subsequently get a diagnostic mammogram. That's the one they always call the super squishy one. But a diagnostic test is because we know you have a problem and we need more data or information because of that problem. So here we're making sure you don't have a problem. Here we already know you have a problem. But from a colonoscopy standpoint, it's the same video camera. It's just how the insurance unfortunately classifies things, okay? All right, a little more on this. This is the full colonoscopy. So yay, here's your booty. So you lay down on your left-hand side, camera goes up, over, down, around, and out. And again, we're just looking for things, okay? Fancy building inspection. This is actually a really, really good website. It's called You and Your Colonoscopy, okay? It's got some pretty cool pictures on it and everything. So this, if you guys seen The Matrix, these look like little, little machines from the Matrix movies. But this is the colonoscope here. This corrugated tubing. So we have our video camera, we have our light, we have air, water, because if we need to have windshield washer fluid, we need to wipe off that, that's everything. And these little pinchers, those are our biopsy things. Now, interestingly, this whole thing right here is only about the size of your thumb. And this thing right here, Anita, what's that aperture? 2 millimeters, 3 millimeters? Yeah, 2 to 3 millimeters. Little teeny tiny tooth graspers. But this entire instrument goes in here all the way down and around, all the way out. So if we do need to take a bite, a biopsy, or remove a lesion, we have the ability with some fancy instruments to snag those off. Okay, and again, this one's done under sedation. Colon screening was at the age of 50. So happy birthday, when you turn 50, it's time to go get a camera. However, because of all of those articles and the data that we had been seeing over the past 5 to 10 years, 5 years ago, actually, the American Society of Colorectal Surgeons changed their recommendations. Again, it's not a law, but these are our guidelines, okay, down to 45. Okay, so now it's happy birthday at 45, okay? And again, that's for average risk individuals. Okay, we'll get into high risk here in a second. Okay, let's talk a little bit about high risk people. Okay, it is important to know who in your family has what, because we know from a genetic standpoint that cancers, unfortunately, tend to run in families. So if you have a lot of cancer in your family, we want to know, do we need to catch you early to make sure you don't get into a cancer diagnosis and we can treat you or prevent it or detect those polyps before they turn into a cancer. So if you are a high-risk individual, colonoscopy is the preferred method, not the FIT, not the FOT, not the poop in the box study, anything like that. Colonoscopy. We consider a high-risk individual any individual that has a first-degree family relative who had a diagnosis of colon cancer or high-risk polyp. That's not important here, but that's like dysplasia or anything like that, under the age of 60. Okay, so if mom had colon cancer at 75, you are not high risk, even though that's a first-degree relative. So high-quality colonoscopy, again, all the way to the cecum, adequate bowel prep, no furniture in the hallway, right? So I can see all the walls. Adequate colonoscopist, adenoma detection rate. We actually get graded on our polyp retrieval and a whole bunch of metrics and everything, and we were able to get everything. And so here it is, risk stratified repeat colonoscopy interval. So if you have a squeaky clean colonoscopy, 10 years. Okay, and that includes poop in the box study. So if we're playing cards, there's always a trump card, right? So if your family doctor says, I think you should have a poop in the box study, a Cologuard study, and you're like, whoa, I just had a colonoscopy 3 years ago, and it was squeaky clean, you don't need to do a poop in the box study because this wins, okay? And again, this is exclusive of symptoms, by the way. So again, if you start to have a change in bowel habit, bloody stools, dark tarry, that's a different reason. If you're living life and feeling good and have already had your colonoscopy and it was squeaky clean, 10 years. But if you had a couple of lesions in there, we're going to shorten the rope on you a little bit down to 7 years-ish. SSP is called a sessile serrated polyp. It's got a little bit of a different risk profile to it. Again, your umbilical cord gets a little shorter. If you have multiple lesions or multiple high-risk lesions, your umbilical cord's even shorter. And if you got a lot of polyps, that's, again, dirty weeds. Okay, if you got a lot of weeds in your garden, you need to tend to that garden a little more frequently, okay? okay? So it all depends on not only how many polyps you have, but it also depends on the type of polyp that you have. And this is our data. So when you go home and talk to your family and you're like, oh, hey, I had my colonoscopy, everybody's good. And your family members say, well, when's your next one? And then you go, I don't know, my doctor said 3 years. Well, why? I don't know, they just said I need one in 3 years. If you come see me, this is why. Let's talk about briefly surgery. Who needs it? When do we need it? Why do we need it? Okay. So if you have a cancer, we need to talk about surgery. Now, I'm not talking about high-risk cancer and a fully resected polyp, but we'll go with the masses here. If you have a high-risk polyp with incomplete resection or a benign polyp that's too big. Now, that pillow test polyp, that one doesn't count. He's exclusive. But some of those giant polyps that we saw in the beginning that kind of look like trees in the hallway, if I biopsy him and he's not a cancer, he's still pretty big. So again, the bigger a weed is, the more worrisome it can be. Okay, so let's go back to this picture. So even if I take these guys off, that's perfectly fine. If I take a biopsy of this and I didn't get them all and he's got cancer in there, that needs to be surgically removed. If I attempt to remove this, but he's as big as a walnut and I can't get it out with the scope, you need surgery, okay? So, and that goes for benign and cancerous lesions. If this guy was pretty big and didn't have a cancer in it, sometimes we have what they're called non-resectable polyps, where even though it's not cancer, it's too big to remove with the video camera, you might still need surgery to remove that, okay? So surgery is kind of a tricky thing, but it all depends on the pathology of what we sampled as well as the biology and size of it as well, okay? Everybody can look at that and go, ugh. Okay, that's pretty nasty. Okay, that doesn't look anything like any of the nice clean polyps or skin tags that we saw earlier. So this is a big fungating mass that's what we call a circumferential mass. So remember what I talked about earlier about the potential of having bowel habit changes of those pencil thin stools. That's the little itty bitty lumen. It's supposed to be this big, but as we can see, it's grown circumferentially, and that's the only spot for the stool to come out there. So that's why we have like a Play-Doh factory stool with a pencil, okay? So that one's bad. Okay, if you have a diagnosis of cancer, we gotta figure out some more information about it before we jump right into surgery, okay? So we always do a workup to determine the staging. That term might become familiar to you guys from a cancer discussion standpoint. We'll get into what that means here in a second. We always do labs and we always do imaging, and this is with a biopsy-proven cancer. So a CEA level is just a blood these are all blood. This is all, go and have the vampires get you. Okay, a CEA is a specific type of tumor marker that's specific to colon cancer. However, not all colon cancers make it, but it does give us an idea of something to track after surgery. It's kind of like a barometer of what's going on the inside of you. Liver function test, this sounds a little goofy, but unfortunately, if a colon cancer is going to spread, the most common place for colon cancer to spread is the liver, okay? Because the liver filters everything in our digestive system first. The liver gets first crack at our cheeseburger, our wine, our diet soda, everything, including anything that's growing in there. And then basic labs too, CBC, or a complete blood count. Are you anemic? Okay, is your colon cancer causing you to lose blood? So these are all important tests. Imaging, we get a CAT scan, chest, abdomen, and pelvis. Unfortunately, colon cancer and other cancers can spread to multiple places on the body. Could spread into the lungs, could spread to the bones, could spread to the liver, the other parts of the digestive system. So we always get a CAT scan, chest, abdomen, and pelvis. This is important with contrast, by the way, but that's for me to worry about, not you guys. So we need to know, does your blood show anything or does your imaging show anything? Okay, so what type of surgery might you need? Well, we cut out the bad part. Okay, now I just don't incise the colon and then scoop out that little thing. Unfortunately, we have to resect portions of the colon, like doing plumbing in your house, and then put the two ends back together with duct tape and baling twine. These are 1, 2, 3. That by definition is automatically stage 4. So based on that information, after we do surgery on you, you might need to go see medical oncology. here, everybody downstairs over at Knox Medical Pavilion with Dr. Rashid and Laura and all the nurses over there, I treat you with surgery, they treat you with medicines. Sometimes you need it, sometimes you don't need it. Also, sometimes people have radiation therapy for cancers. I just want to throw that out there. There's no such thing as radiation therapy for colon cancer. Okay, so it's only surgery and medicine.